Good afternoon. I'm Bill Galantine. I'm a pediatric epileptologist at Stanford University. Thank you so much for joining us today for today's webinar entitled Pediatric Diagnostic Dilemmas, Epilepsy. Our webinar today will be geared toward primary care clinicians, but it will cover topics relevant to pediatric neurology subspecialists as well. And so we'll be having three case-based discussions and cover a wider range of topics across the field of pediatric epilepsy, including epilepsy genetics, epilepsy surgery, and infantile spasms. Today we will be using the Q&A feature on Zoom, and so any questions that you have, please just put those in the Q&A. We'll be using the chat function predominantly just for any technical issues, so please use the Q&A to distribute those. So today we'll have three speakers. I will be starting first and talking about an epilepsy genetics case, and then we'll also be joined by two of my colleagues, Dr. Ann Heslop and Dr. Emily Spellbrink. And I'll introduce them further as we kind of go along. So we're gonna go ahead and jump right in. Okay. So this first case discussion will be a genetic epilepsy case. Past medical history significant for 26-week prematurity, aortic stenosis, status post-repair, 4 years of age, no reported complications. Epilepsy onset was at 10 months of age and had focal right-sided clonic seizures. Epilepsy was drug resistant through that early course, really requiring 5 agents: phenobarbital, phenytoin, levetiracetam, zonisamide, and valproic acid. MRI was normal initially, and development up to that point had all been also age appropriate. Then at 14 months of age, he presented with generalized febrile status epilepticus. This was initially treated with lorazepam, phenytoin, phenobarbital, and then ultimately required a midazolam drip. The EEG actually was showing continuous generalized spike and wave. A single dose of pyridoxine was given, 100 milligrams, and without any significant changes to the EEG. And the seizures eventually stopped after about 48 hours with maximization of the midazolam drip, levetiracetam, valproic acid, and zonisamide. This course was actually complicated by pneumonia requiring prolonged intubation, as well as hypotension requiring pressures, and then ECMO for 2 weeks. And then repeat neuroimaging and metabolic testing was all negative. Between 14 months of age and 8 years of age, the child actually had rare focal seizures. They were predominantly left-sided clonic, starting in the left hand. And he would have like one per year or one every other year, predominantly triggered by fever, but did require being on 4 different agents: levetiracetam, phenobarbital, valproic acid, and zonisamide in combination. Any attempt to wean those meds reportedly had resulted in breakthrough seizures. He did have a mild expressive delay, but otherwise development continued to be normal. Then at 8 years of age, he develops fever, URI symptoms of vomiting, and is ultimately diagnosed with flu. And because of the vomiting, he's having a difficult time taking his medication, so he starts having more frequent generalized tonic-clonic seizures. And at that point, he is admitted to an outside hospital again and treated for status epilepticus. Once again, phenobarbital, valproic acid, lacosamide, and levetiracetam were used. And actually ultimately required a midazolam drip for 5 days. And they were really unable to wean this due to frequent breakthrough electroclinical seizures. Seizures at that time were continuing to be left-sided clonic, but also having associated staring with desaturations and teeth grinding. And then he also would have similar events involving the right upper extremity, as well as a third type of spell with intermittent bilateral facial twitching. Due to the inefficacy of the midazolam, he then was switched to propofol for 48 hours and was placed in the burst suppression, on which he had developed the complication of acidosis. Because they were kind of uncertain as to where to go next, they ultimately decided to place a VNS with hopes of actually breaking the status. And then was ultimately then switched to phenobarbital for 5 days and placed in the burst suppression coma. Again, at that point, he continues to have electrographic seizures with any time they would attempt to wean the pentobarbital. He then gets pneumonia and also requires hypotension, as many patients on pentobarbital coma typically do. And neuroimaging continues to be normal. So at that point, he's transferred to our institution for further management, and he comes to us in pentobarb coma in burst suppression. And the question for us was, would we potentially consider him for ketogenic diet? And here's his initial EEG when he comes to us. You can see here he's got a flat EEG with a burst of abnormal electrical activity, consistent with burst suppression coma, and this is on day 7. And so the questions for us then, which was our next steps in management? And as in once you get to refractory status, there's many options that you potentially can have, none of which actually have great literature in terms of how to approach. So with things that was considered included ketamine and inhaled anesthetics, ketogenic diet, immunotherapy was discussed. But then also just the question of, he's now been 48 hours without any attempts to wean the medication. Should we just try to wean the phenobarbital and see for ourselves what actually happens? And that's the route that we decided to do. One of the reasons that because of that is because of the report of these electrical discharges that were coming up as they became the wean medications. And so this is the pattern as we wean that kind of came up, and you can see he has these generalized discharges. For those of you who aren't familiar looking at EEGs, you can see these spikes that are occurring kind of at a rate of 1 hertz as we wean his medication. But there was really no associated clinical seizure with this, just these generalized 1 hertz discharges. So in looking at the EEG, we then said, okay, now what? So now we've gone from a burst suppression pattern to this generalized periodic pattern. Where should we go next? And should we restart the pentobarbital? Should we rediscuss any of those agents we have? Or should we, again, kind of take the approach of watch and wait and see if electroclinical seizures come up? And there is this phenomena that is known as GRAWLs, so generalized periodic discharges related to anesthetic withdrawal, that can occur whenever you're withdrawing these agents such as pentobarbital and propofol, and they actually will have these 1 to 4 hertz generalized periodic discharges that occur as you're coming out of coming out of burst suppression coma. The pattern typically remains for about 12 to 48 hours, and then it resolves. And although at times it may kind of look like somewhat ictal, it typically is transient and resolves without any real treatment, and it is associated with clinical improvement as it's resolving. And so kind of one of the key things about it, though, is it's really not really associated with any clinical ictal signs. And then it oftentimes can be reproduced. So if you put the patient back into coma and then bring them back out, you will see that the same phenomena typically occurs. So here's an example of a 7-year-old that had this type of phenomena. He's in burst suppression, and you'll see as we lighten the burst suppression, we start getting these spike-looking discharges again, kind of at 1 hertz. At that point, it's actually very generalized as we became very continuous. And then over time, this is 12 hours later, you see the spontaneous remission. And so this was what we were thinking, at least at this point, because he had now had 7 days of burst suppression. We're looking to potentially try to get him off because he's having complications. We wanted to let it ride and see what would kind of happen with our patient. But then unfortunately, he starts developing this. What the video is playing. So basically, we end up seeing a little bit of right or left leg jerking and bilateral eyebrow jerking and twitching as well. And so, which really raised concern for twitching, or raised concern for seizure activity. So in looking at the EEG, what we see now is that you are starting to get, again, very frequent, very angry looking discharges here, particularly in the right temporal region, which then begin to clearly evolve. And at some point, we actually see a clear evolution into seizures. And this is correlating with the twitching that we're jerking that we're kind of seeing. And so at this point now, we have had a kid that has failed midazolam, propofol, pentobarbital, phenobarbital, as well as his home agents that had previously listed there. There also was some attempts to titrate up the VNS that had been placed acutely at the outside institutions. And then we kind of came back to the same questions. So those same treatments that we were discussing previously, where do we go from there? But right before we were ready to do that, we are now on day 3 of our admission and day 17 overall of refractory status. We get a phone call from mom to dad. Now, at this point, as I said, this patient was transferred from an outside institution and actually took the parents, actually, the father actually over a little over a day to get to our institution. And then, like I said, it was day 3 before we actually heard from mom. But mom volunteers that the dad should actually tell us about the brother's history of epilepsy. And they're actually, those seizures were actually controlled with some type of vitamin. And she wonders whether that vitamin would work for our patient. And in fact, this patient does indeed have paradoxine-dependent epilepsy, so vitamin B6 dependent epilepsy. So with that, armed with that information, rather than going down the road of all those other agents we discussed about, we decided to revisit vitamin B6. Now keep in mind that B6 had been given to this child for seizures very early on in his neonatal course without any response. But we decided to revisit, obviously, because of the family history, and here was the response. You can once again see that the EEG is very abnormal with these generalized spike wave discharges. And as we kind of move along, you're going to see that they start to dissipate. And here's where our B6 infusion has just completed. You see they're less generalized. Now you're predominantly seeing them just on the right side. And then just within a minute or two, you see that they melt away. And really without any further epileptic discharges. So this is an example of paradoxal-dependent epilepsy. Paradoxal phosphate in epilepsy, paradoxal phosphate is actually an active form of vitamin B6 and is a cofactor that really will enzymatically catalyze over 100 reactions, including synthesis and catabolism of neurotransmitters, including GABA. And there's really two genetic epilepsies that we predominantly see that is associated with paradoxal phosphate deficiency, and that would be paradoxal dependent epilepsy, as well as paradoxal 5-phosphate dependent epilepsy. As far as paradoxine-dependent epilepsy is concerned, this is an autosomal recessive condition secondary to mutation in ALDH7A1, and it does result in inactivation of paradoxal phosphate and decreased GABA levels. And typically, these are going to present with drug-resistant neonatal seizures, but onset actually can't even be prenatally, and moms may report the sensation of hiccups during their pregnancy, which are oftentimes a manifestation of intrauterine seizures. But in general, the seizures are usually in the first few days of life, and they can be all sorts of seizures, including focal, multifocal, myoclonic, generalized tonic-clonic, and then actually even infantile spasms at a later date. Diagnosis typically is clinical in the short term because we usually are on relative high alert for this particular condition early on. Even without any form of genetic testing or biochemical testing, we oftentimes will do a clinical trial of paradoxine at 100 milligrams IV, and then oftentimes this should be kind of followed or repeated up to 500 milligrams. Because not all patients respond to the first dose. And what may have happened actually with this particular patient is that he didn't have a good response to the first dose, but potentially with repeated injections, they may have seen something. But also if there's no response within a minute, it's still a good idea to place them on oral paradoxine for a few days to see if you actually get a response. And that's usually at 30 milligrams per kilogram. Typical maintenance dose is going to be anywhere from 50 to 200. You also can do screening metabolic labs, which include alpha aminoadipic semialdehyde and pipical acid, which are elevated during these with this condition. And then ultimate diagnosis is confirmed with genetic testing and ALDH7A1 gene showing genetic changes. There are atypical presentations of this, though. So this is a small case series that looked at 65 kids. 70% of them do have typical neonatal onset, but another substantial percentage of them actually are a little later. So 12% at 1 to 2 months, and 17% was greater than 2 months of age, and even one of them presented at 9 months of age, and another at 2 years. So there can be this delayed onset. You also can have these seizure cessation periods that could be quite long, even months to years, even without the initiation of paradoxine. I think this is something that so can leave some folks astray and thinking, well, it can't possibly be paradoxine because they didn't. How could they have been seizure free without it? And so people don't necessarily think about it in older kids. And then also, as I mentioned, you may actually have that initial lack of response to that 100 milligram dose, and that too could kind of lead people astray sometimes. So Typically, so with our patient here, an epilepsy gene panel was sent and actually did reveal a mutation in the ALDH7A1 gene, and he's remained seizure-free on vitamin B6 at 100 milligrams daily, and we've been able to wean off all of his other medications. So this is a child that has had two very long bouts of status epilepticus lasting several weeks, requiring numerous different medications, was on 5 medications throughout the majority of his young life. Um, and was able to come off all of those medications once the diagnosis was made. So why did I go to the trouble of discussing this ICU case with an audience that's predominantly made out of general pediatricians? And the answer to that is that it all could have been avoided if genetic testing really had been done and considered. And so it's my goal to show this case because is one that really kind of stands out, that interventions potentially could be made, and those interventions potentially could have avoided a very difficult course, and also to put it on your radar for something that you guys should be thinking about as you potentially see patients in your clinic with epilepsy. So if we look at the common causes of epilepsy, almost 70% of them are actually genetic. And so with a portion of them actually being more monogenic single gene epilepsies, and then there's a spectrum of other epilepsies that actually are kind of more complicated with varying degrees of inheritance, as well as other modifiers and susceptibility alleles that also play a role. When we look at the spectrum of genetic epilepsies, there's a number of different types of epilepsy syndromes that have been kind of shown to have genetic etiologies. It's really all walks of life within epilepsy, everything from known epilepsy syndromes like Rett syndrome and Angelman syndrome to structural abnormalities with congenital brain conditions, to even benign infantile convulsions and other genetic generalized epilepsies. All of these have been associated with various different types of gene mutations. And then certainly our spectrum of more malignant epilepsies, of epileptic encephalopathies and progressive myoclonic epilepsies, many of these have been linked to genetic conditions. Whenever we look at our genetic testing options, there are a number of options that are available for us to think about. The first is kind of just your standard routine karyotype, which really is going to detect large structural chromosomal abnormalities. And these are going to be highest yield in patients that actually have dysmorphic features or fit specific syndromes. You also consider doing targeted single gene sequencing or deletion duplication analysis, methylation studies, or FISH studies in a scenario where you actually have a very specific syndrome that you think that you might want to target. So for instance, Rett syndrome that has a very specific clinical phenotype, you might consider doing specific deletion duplication analysis or gene sequencing. Chromosomal microarray is another technology that many folks are familiar with, and this is really going to detect abnormalities within copy number variants, so deletions and duplications, typically greater than 1,000 base pairs. These typically will detect most abnormalities in chromosomal number as well, so things that would likely be picked up on your karyotype, like trisomies or monosomies. It will detect most unbalanced rearrangements of a chromosome or translocations, but it typically will not detect small changes in single genes, so point mutations or tiny duplications or duplications or deletions, and oftentimes won't pick up balanced chromosomal rearrangements like translocations or inversions that are balanced. And then lastly, there's next-gen sequencing. So whole genome sequencing is going to be that of sequencing the entire genome and looking at both introns and exons, with introns being your non-coding regions and exons being your coding regions. And then your whole exome sequencing, which really is going to be sequencing just the exons only, which is where it is felt that the majority of human disease actually occurs in regards to genetics. And then as a subset of these, there's these epilepsy panels, which actually uses whole exome sequencing technology to really do analysis of a specific number of epilepsy genes. And so, and these panels can range anywhere from 8 genes up to 400 genes, depending on which company you order them from and which panel you would like. Next-gen sequencing is not 100% either, though. There still is some small deletion and duplications you may not detect. It used to be the copy number variants would be detected on whole exome sequencing. More recent testing has actually shown that they may have now have the technology to be able to do that, but they won't detect structural rearrangements, methylation abnormalities, or non-coding abnormalities. So what is the diagnostic yield of genetic testing in our patient population? And so this was a nice meta-analysis that actually looked at patients with epilepsy and unknown etiology. And they looked at 8 different chromosomal microarray studies, 9 epilepsy panel studies, and 6 whole exome sequencing studies. And they found that West certainly had the highest diagnostic yield, followed by epilepsy panels, and then by CMAs. Um, for for generic cases of epilepsy of unknown etiology, certainly whole exome sequencing and epilepsy panel seem to be more cost effective than CMA. However, the exception to this would be is if the patient actually had intellectual disability, autism, or dysmorphic features. In that scenario, the CMA was more cost effective, and it does have about a 10 to 15% diagnostic hit rate. Whenever we look at the epilepsy diagnostic yield, it is directly proportional to the number of genes that are on the panel. So they looked at this particular study looked at the panels that range from 11 to 300, and the range was anywhere from a 4% diagnostic all the way up to 48% diagnostic for the higher number of yield or for higher number of gene panels. So, so certainly the more genes you're testing for, the higher likely you are to potentially find something. And the most commonly implicated genes were those of SCN1A, KCNQ2, CDKL5, SCN2A, STXBP1, and PCDH19. And these made up about 50% of all the genetic epilepsies that were actually diagnosed. So they actually were relatively common. There are some clinical predictors that will predict a higher diagnostic yield. So certainly if you're an early onset epilepsy, so less than 1 or 2 months, that substantially increased the diagnostic yield, as well as having drug-resistant epilepsy. So if you're seeing patients in your clinic that their seizures started at a very young age or they're drug resistant, we definitely want to make sure that they've had an adequate genetic evaluation. And so, and this may start with just asking the family whether they've had genetic testing and then what testing has been done. And then if it's uncertain, reaching out to their neurologist and seeing if they've had an adequate genetic testing. So what is the impact then of this genetic testing? Well, oftentimes it really just provides the answer to why. And a lot of times these families really are beating themselves up looking for answers. A lot of times there's actually a lot of self-blame in terms of thinking that they may have done something during their pregnancy or something that may have resulted in seizures. So having that answer, the question of why answered, oftentimes can really be helpful. But also as an end to the diagnostic odyssey. So oftentimes we are just left looking and doing more and more tests. And if we're ultimately able to come to a diagnosis, then that actually then brings that to a close. This then avoids future unnecessary testing. It also may inform decisions about future reproductive decisions. And then lastly, it actually may lead to specific targeted therapy for a substantially growing number of disorders. And this may actually result in specific modification to the disease in a dramatic way, much like we saw in our patient. So here's just a list, and I'm not going to go through all of these, but it's just a list. This goes to show you, at least at this point, these are a list of diseases that have therapeutic implications of their genetic testing. We have very specific disease therapies that we can use to modify these diseases and actually have great impact. So our take-home points then is genetics certainly are by far one of the most common causes of epilepsy. The phenotype of the genetic epilepsies will vary greatly, and those that have early onset and drug-resistant epilepsy are higher risk for developing, for having a genetic disease. Genetic testing can provide an answer in nearly 50% of the cases, depending upon which type of test we're looking at, in those cases that are of unknown etiology. And then the results can have substantial therapeutic implications as well as ending the diagnostic odyssey for families. So my plea for you for this today is if you're seeing patients with epilepsy, especially those that are still experiencing seizures, make sure that they've had an adequate genetics evaluation. Remember, the higher number of gene panel they have, the greater the diagnostic yield. So you would like for them at least to have had a high number gene epilepsy panel, but potentially even consider whole exome sequence. And then certainly a referral to a tertiary care center for a genetics evaluation would be warranted. So it does take a village to take care of these patients. So this is just our epilepsy genetics program here at Stanford. You can see that we have all of our epileptologists within the division see patients with genetic epilepsy, being that is such a large number within our patient population. We do have a couple subspecialty clinics that are aimed at kind of looking at epilepsy genetics and actually looking to see if there's changes that we see in the DNA and it's uncertain as to whether we can sort those changes out. And so there are several of us that work within that. And then Dr. Porter has a tuberous sclerosis multidisciplinary clinic where we see a number of patients there with our genetics folks. And then Dr. Wusthoff also does neonatal epilepsy and has some crossover with genetics as well. We have a full neurogenomics team, as well as dietary and nursing and case management support as well. So with that, I will pause and take some questions before we get to our next speaker. So let's see. It looks like the first question that we have is at what point would we consider ordering a routine karyotype chromosome microarray for a patient with epilepsy after patient goes on multiple AEDs or multiple breakthrough episodes? So traditionally, if it's how I kind of approach it would be is if there is, particularly for microarray or chromosomal karyotype, if there is any dysmorphic features at all, any microcephaly, any intellectual disability or autism, I definitely would do the routine karyotype microarray first. If not, then oftentimes I'm starting with epilepsy panels because the hit rate is higher. And then if there's something else in the history that would lead me to one of those other tests, then I would consider doing that. And so more and more, particularly since there is a company that typically will test all children for under the age of 8 for a genetic panel for free. We've been sending that off on almost every child that we see who comes in with epilepsy. So those would be the main things that we would be thinking about. Okay. All right. Any other questions?
Bill, I think there's one in the main chat.
Okay.
Which says what to do in case of no response to oral route.
And I'm assuming that is in response to
I think that's pyridoxine.
Pyridoxine.
Referring
so
to.
Yeah, so I think that in general, you're going to start your diagnostic trial with the IV, and then from there you would then go to placing on oral, and you would remain on oral oftentimes until the patients then have their genetic testing that's cleared them. So if the genetic testing comes back negative, then we would take them off the vitamin B6. Or if you feel like you've gone a trial of 1 month and hasn't had any response, then it's reasonable to discontinue. And then certainly if you had worsening, you would reevaluate. There is a subset of patients who do have that may not respond, and they may require other anti-epileptics in addition to the B6. And usually if I have that diagnosis, I still would keep the B6 on, but then we would consider using other agents as well. All right. Well, if there are no other questions, I'm going to go ahead and I'm going to stop my share, and I'll introduce, actually before I do that, I'll stop my, yeah, let's go ahead.
There's another question about, would you offer genetic testing to adults with long-term refractory epilepsy or like LGS?
Yes, I would. And so, because again, there may be some opportunity there for some potential targeted therapy that may lead you in a different way in terms of how you're managing your patient. And so oftentimes in those scenarios, obviously reproductive counseling for parents is not something that's very high, but it could be something that may impact other family members or things like that. So getting more information from that perspective, I think, is always helpful. All right. So with that, I'm going to transition over to our next speaker. So our next speaker is Dr. Ann Heislop. She's a clinical associate professor here at Stanford in the Department of Neurology and Pediatrics. She trained at the University of Washington, where she did her child neurology residency, and then did her epilepsy fellowship at Miami Children's Hospital. She just recently joined us here on faculty and has special interest in epilepsy surgery, which she's going to speak with you guys about today. So with no further ado, Dr. Heislop.
Great, thank you so much, and thanks for having me here. I'm going to have a case-based discussion about epilepsy and the role of epilepsy surgery in our patients. After this presentation, I hope that you're comfortable detecting some missed opportunities for children with epilepsy and identifying those that warrant referral to an epilepsy center. I also hope that you're going to be more comfortable supporting medical decisions for children with drug-resistant epilepsy and supporting their families. So I'm going to start with 2 cases of epilepsy in childhood based on cases that I've had myself. The first is, we'll call Curtis. He's a 7-year-old male with epilepsy onset, age 3. He has what people call generalized tonic-clonic seizures. Initially, he had 3 a year, and then they escalated over a few years to the point he's having 1 per month. He tried 1 anti-seizure medication previously and is now on 2 different ones, valproic acid and levetiracetam. This is Raj. He's now 8 years old, and he had epilepsy onset at age 5. He also has been told that he has generalized tonic-clonic seizures. Initially, they were happening once per week for a month, and then he had none for a year. Now he's having 1 a month. He too is taking 2 ASMs every day, lacosamide and lamotrigine at maximal doses. So Curtis's ictal video EEG captures an EEG that shows he has a seizure that shows he has secondarily generalized seizures. Actually, the onset is in the left posterior temporal lobe. The MRI, though, is normal. So his parents are told, well, the next medication might work and that there's really no clear target for surgery. So his valproic acid is increased and he experiences some amount of weight gain. His seizures continue, and then lamotrigine is started, and then unfortunately he develops a severe rash. Meanwhile, Raj has an EEG, captures a seizure as well, and there's no focality at seizure onset. But review of the video taken with that EEG shows that he has a behavior change that occurs before the GTC starts. His MRI, though, is also normal, but his parents are told that his seizures appear to be focal at onset because of that behavior change, and more evaluation is warranted. They're told that his chance of finding a seizure medication that will result in seizure freedom is very low. An admission for pre-surgical evaluation for him is arranged. Meanwhile, Curtis is admitted because of his rash. His lamotrigine stopped, and he started on oxcarbazepine. His valproic acids continued, and he stays on levetiracetam. He's discharged once the rash, which it looks like a Stevens-Johnson syndrome, appears to be improving. On his new meds, though, his seizures continue once or twice a month. His parents are increasingly worried about aggressively treating his seizures at this point because of the side effects that he's suffered. Meanwhile, Raj is also admitted for his pre-surgical evaluation. He undergoes a video EEG, but this time they put extra electrodes in his EEG montage on his head. With these, they're able to show that he has onset in the left parietal lobe. Sorry, let me go back. And a high resolution MRI is done on Raj, and it's done along with a functional MRI that shows where his language, his vision, and his motor functions are. It's still normal, but an interictal PET scan is done, and it shows a region of hypometabolism that corresponds to the epileptogenic region that's seen in the left parietal region. His parents now have some hope. Within a month of discharge, Curtis has gained 10 more pounds, and he continues to have seizures. During a seizure, he falls and he chips his permanent front teeth, and he sustains a severe eyelid laceration that requires repair and barely misses his globe. His oxcarbazepine is increased at that point, and he stays on valproic acid and levetiracetam. Meanwhile, after Raj is discharged, the epilepsy surgery team meets and they discuss his case, including his EEG, his co-registrations of all of his imaging, and a 3D source localization done on an EEG. And at the end of the week, the team calls the parents and offers them a stereo EEG to determine the limits of resection within the left parietal lobe. Back to Curtis, 3 weeks after his big fall, he has a seizure while he's asleep. The parents find him in the morning convulsing and they call 911, and they don't know how long the seizure lasted. He receives IV medications that eventually stop his seizure after several hours and remains in the hospital for 2 weeks. And he's discharged on levetiracetam, valproic acid, phosphonatoin, and lacosamide. He's tired, and he's sad that he can't be like what he calls his normal friends. And now he's grossly overweight, 45 pounds over his ideal weight. Raj has an SEEG scheduled in the next month. He continues to have seizures in the interim despite medication adjustments, and he's having stomach aches because of the meds, and he hates taking all of them. Eventually, Curtis has been absent from the 3rd grade so many times that he's got to repeat it. And in class, he has a seizure and he hits his head on the desk. And his parents are so fearful, they actually remove him from school because they're afraid of more falls and more injuries and another prolonged seizure they can't control. By the age of 10, he's 60 pounds overweight, and he actually uses a wheelchair for transport to avoid multiple injuries that he keeps sustaining from seizure-related falls, and to also prevent his parents from having to lift him off the floor each time. Raj undergoes a stereo EEG, which delineates a small area of abnormality in the left parietal region, and he undergoes thermal ablation of the region. He's weaned off one of his ASMs a few months after surgery, and then after 2 years of seizure freedom, he's taken off the last ASM by age 10. Curtis, meanwhile, goes on to suffer more seizures, more medication side effects, worsening memory. He doesn't receive a high school diploma. Around the time he's 21, his seizures change and for the first time appear really focal. So an MRI is repeated, and now he has developed left hippocampal sclerosis, which is now secondary to the recurrent seizures and prolonged seizures that he's had in the past. The original seizure focus that we used to see in that left posterior temporal region, still active on EEG. So he continues to have seizures once every 6 weeks and now lives in a facility because his parents can't safely take care of him at home. Raj goes on to do well in junior high and high school, receiving average grades. He struggles with anxiety and has difficulty with attention, but his seizures, they never come back. His parents work and can concentrate really now to get him into school-based counseling and to see his neurologist to discuss attentional issues. But he graduates and attends college as far away from home as possible, but he never, ever has another seizure. So both of these cases illustrate the most poignant aspect of this is the sad truth about our anti-seizure medications. They're not great. And once you've failed 2 appropriately chosen and dosed anti-seizure medications, you're considered to have drug-resistant epilepsy. Kwan and Brody defined this term in 2000 when they reported an incident that the incidence of seizure freedom with the first ASM that's tried is around 50%. Those that fail that and go on to try a second ASM, they only achieve seizure freedom in 13%. If you've been on 2 and they've been appropriately chosen, appropriately dosed, the chance that you will find seizure freedom on ASM number 3, 4, or 5 is less than 5%. Which is where epilepsy surgery can come in. Epilepsy surgery may actually offer you seizure freedom and a life off of medication, while medication might just offer seizure control. In 2010, McCarty actually did a study where they looked at patients versus controls, patients that underwent surgery. And those that underwent surgery, 79% of those remained seizure-free for 2 years after surgery, and only 21% of the non-operated controls achieved seizure freedom. In 2009, a large meta-analysis of 20 studies was done, and it showed in all comers, even those that underwent palliative surgery and those with large malformations. So in all comers, 44% of those that had undergone surgery remained seizure-free. Only 12% of those that were medically managed remained seizure-free. So in children, the story is the same. Now, this is an interesting study that was actually published in 2017, done in New Delhi, where when a child is identified as a good surgical candidate, they go on a wait list, and that wait list is usually 12 months or more. So what this group did is they randomized children after they were determined to be good surgical candidates, and 57 of them underwent surgery within 1 month of randomization. 12 months later, 77% of that group was seizure-free. versus only 7% of those waiting to have their surgery in the medical group. They found not only significant differences in seizure outcome, but they also found significant differences in the seizure severity scale in those continuing to have seizures after their surgery, as well as in child behavior checklists and then quality of life scores and social maturity scales. But epilepsy surgery is grossly underutilized. Approximately 30% of children with epilepsy have drug-resistant epilepsy, and an estimated 10 to 50% of those are surgical candidates, but only 1 to 11%, depending on the study, of those undergo epilepsy surgery. So those at risk of missing this opportunity are largely non-white children. They are less likely to have epilepsy surgery at all. They're less likely to undergo a pre-surgical evaluation. And even if they do make it to surgery, they have longer durations of epilepsy prior to surgery. Older age and childhood, Medicaid insurance, and the presence of another chronic illness are associated with a lower likelihood of entering into pre-surgical testing. And interestingly, those traveling shorter distances to a referral center were older at the time of surgery, likely speaking to those that live around referral centers being a potentially lower socioeconomic status in urban areas. One of the biggest issues that we have are attitudes towards epilepsy surgery. Understandably, there is a big fear about the fear of undergoing brain surgery. But there are poor information sources out there that help our patients and their families understand what the risks are of not undergoing it as well as undergoing it. Pre-surgical evaluations, once you start, they can feel slow and they can be confusing. And probably the biggest obstacle we have is epilepsy surgery is seen as a last resort, meaning people feel they have to try every medication and every diet and every device before they can consider doing some type of surgery, which is just not right. So back to our cases, Curtis and Raj, both had generalized seizures, both had normal brain MRIs, but we had to ask ourselves, are they really generalized? And this takes some evaluation by an epileptologist to really understand. And so we've learned, does having a normal brain MRI contraindicate like further evaluation? Absolutely not. Both of these children met the definition of drug-resistant epilepsy. So will a different medication cause them to become seizure-free? Chances are vanishingly small. Will a super therapeutic dose help? No. Why try and risk the side effects? So in Curtis's case, he struggled with significant side effects to ASM. Did the providers he was dealing with see a possible exit ramp to the downward spiral that he experienced? I don't think they did. And in Raj's case, he embarked on a pre-surgical evaluation without even knowing if he was going to be a surgical candidate in the end, but they knew it was worth trying. They knew what they were up against if they didn't try, because his risk of continuing to have seizures was quite great just using medications. The missed opportunities in Curtis: he wasn't referred for a pre-surgical evaluation after the failure of his second seizure medicine. The providers didn't understand that even if he had a normal MRI, he could be a great surgical candidate. The parents weren't counseled about their concerns about his side effects, and they weren't counseled about the resources they may have access to help them through this process. No one invited them to learn about alternatives in epilepsy management, alternatives to medications. And no one said, just why don't you get a second opinion? And probably the most tragic part of Curtis's case is he developed a second seizure focus that was likely avoidable if he had had timely removal of the first. Raj, meanwhile, had timely referral to a level 4 epilepsy center, and as epileptologist just looking at his video was able to say, wait a minute, we may have a surgical candidate here, even though everything looks generalized, the MRI looks normal. And then with his case, there was deployment of multiple pre-surgical evaluation tools in order to help understand exactly where that seizure focus was and how close to eloquent tissue it was. So I'm just going to briefly run through what these types of things are. So brain MRI, the brain MRIs that we typically do on patients aren't necessarily epilepsy surgery protocols. For epilepsy surgery, we do 1 millimeter cuts in every direction, and this helps with our sensitivity and detection of a lesion. And this can increase from 39% to 91% if you're using an experienced neuroradiologist and optimal MRI acquisition. We can actually also apply post-processing to MRIs to do things like voxel-based morphometry, which increases sensitivity for focal cortical dysplasia by comparing children's thickness of cortices and the appearance of them to standards. And this is a video that shows an MRI that I post-processed with VBM, and is able to show how beautiful the gyri and the sulci are. And this is just from an epilepsy protocol MRI, and really helps us with detection. A functional MRI can be done at the same time, at least in our center, can be done at the same time as acquisition of a high resolution MRI. And this allows us to map language, vision, and motor networks on that patient's actual anatomic MRI. And in this video, I've co-registered a FLAIR image, so it looks a little bit grainy, and you can see that there's a focal cortical dysplasia here at the bottom of this sulcus. Unfortunately for this patient, this is occurring in the area of hand. And so we wanted to know how close is the area of hand. So co-registering the functional MRI shows us the bold signal that popped up, and this is the area of the hand function in this child's brain. Now, the epileptogenic focus was deep to this area and implied a risk at the time of surgery of losing some degree of hand function. Now, at our institution, we also do transcranial magnetic stimulation, which is a way to awake map a child's brain, and it allows us to more precisely map the, actually even the finger activity, the finger function on the surface of the brain. So we can map things like language and motor using just magnetic stimulation through the skull while the patient just sits in a chair. And so that we can actually put that on the anatomic MRI and also co-register that with our other modalities as well. So video EEG for ictal capture is the mainstay of our evaluations. And Dr. Spellbrink has some wonderful videos she'll go over later. This is just an attempt at one to show you how valuable the EEG can be. And a baby who has normal movements and suddenly becomes very quiet and just looks like a typical baby quieting, but is actually a type of seizure. So looking at EEGs and looking at the video even can help us to understand if somebody's a surgical candidate, as well as where the seizures are starting and where they propagate to. So one of the more interesting things that we can do for as a potential surgical candidate is we can actually take the electrical information off of the patient's EEG and co-register it to their anatomic MRI. So the EEG signals are actually post-processed, and we can do this just using a software. And so that we can show where the seizure onset starts, like in this picture, and where it propagates to. And then we can actually co-register that to the patient's MRI, not just a brain model, and it will tell us a lot of information about localization and propagation. Studies have shown that if you resect the maximal area of activity as defined by electrical source imaging, then you're going to get a better surgical outcome. PET scan is a way that we can look at kind of a heat map of someone's just resting metabolic state in the cortex. And PET scan allows us to look for areas of hypometabolism. So when a brain is used to having seizures and yet isn't seizing at the time that you collect the scan, the area that generates seizures is tired out. So the metabolic rate is lower. And so we can see a dropout of the signal. And in this patient, you can see one in the frontal lobe here, and it may look a little bit hard to see, but when you compare it to the other side and what it should look like, you can see a definite area of hypometabolism. And seizure freedom rates are definitely higher postoperative when this area is resected. We try now not to resect the entire area because we know that there are some areas within this that are more epileptogenic than others. One of the tests that can help us to identify that area is a SPECT scan, which I'll show you a picture of that in a minute. But a SPECT scan works off the theory or the fact that seizures actually increase blood flow at the seizure onset zone by up to 300% for a very short time after the onset of seizure. So a SPECT injection, usually we try to do it within the first 10 to 20 seconds of seizure onset. So a nuclear medicine tech sits by the bedside, ready with a radionuclide. And as soon as the seizure starts, that's injected into their peripheral IV. And then the scan is done within the next 4 hours or so before the nuclide is washed out. And it generates a more focal and accurate representation of seizure onset zone in many patients. And this can be helpful, particularly when the PET is not. But here I'm going to show PET inspect co-registered, and co-registration of multimodal data has actually now been shown to improve post-op seizure outcome and actually can reduce the need for an invasive EEG in patients. So you may not have to do any sort of invasive procedure before the epilepsy surgery itself, because you do these in the pre-surgical evaluation in a non-invasive way. So in this video, I have a brain MRI, and that is normal brain MRI. All the sulci and gyri look perfectly normal, no sign of dysplasia. And then peeling back the layers of the MRI, you can see the PET. This is the metabolic state, the resting metabolic state. And we can see there's a drop out of the signal here. But that didn't seem to be the whole story for a variety of reasons in this patient. So a SPECT was done. I co-registered it here in 3D. And what it reveals is there's an area also active here in this region, which required interrogation to decide which of these areas was the driver in this child's seizures. It turned out to be the lateral one, which after which we removed it and he was seizure free. He and our patient Raj had undergone stereo EEG, which is when we place thin, flexible electrodes that are stereotactically placed through small burr holes in the skull, and it allows us to assess the EEG from deep regions. Electrodes are placed that have between like 4 and 16 contacts into the depths of the brain. And we see an EEG much like that we see from the scalp EEG, but it tells us where seizures are starting in these deep structures that may not even show up on the scalp EEG. So in this case, we can see that there is a seizure that starts in these areas, but not in the deeper areas that we have in other brain regions. Now, we still use conventional implantation of grids and strips, where we take off a portion of the patient's skull and lay down a silastic sheet full of platinum electrodes. And this is particularly important when we're trying to map out motor function that is abutting an area of epileptogenic cortex. And so we need to be accurate to avoid any kind of motor or language deficit if it's near expressive or receptive language. And so this is still a very, very helpful approach, but its use is being minimized over time with the application of stereo EEG. Certainly, stereo EEG, excuse me, is considered to be more safe than doing a conventional open grid and strip procedure, with a meta-analysis showing significantly lower rates of CSF leak, hemorrhage, and infection, understandably. So our patient underwent, for his curative portion of his procedure, he underwent an MRI-guided laser interstitial thermal therapy, or LIT. People call this laser for short, but it is a thermal technique where a stereotactic metal filament is placed into the brain through a burr hole, heated and withdrawn as the heat is being applied to the cortex, and then the surrounding tissue in approximately up to a 2 centimeter diameter is ablated, and you can control the diameter, and you can of course control the length of the axis that you're ablating. Interestingly, this doesn't interfere with vascular structures like vessels, because the blood being pumped through that vessel cools those so quickly that only the tissue is ablated, and it causes destruction there. And so this shows these 2 filaments placed in the superior temporal gyrus of this patient. You can see the ablation zone after they are complete. And so this will cavitate, become encephalomalacic over time. And the scarring that it leaves behind, much like our rest of our surgeries, is not typically epileptogenic in and of itself. So how efficacious is epilepsy surgery? Well, the answer to that varies depending on the institutional experience, as well as how thorough the pre-surgical evaluation was, where in the brain the location of the surgery is, and then the existence of a lesion, or if the brain is considered non-lesional. It also, of course, depends on if you are sure you have removed the entire epileptogenic focus, as well as some other factors. Overall, seizure freedom rates in children range between 54 and 80%, depending on the study, and they are improving over time. They are highest in those that have, in children that have lesions that are visible on MRI, but they're also quite high in those that have seizure onset within the temporal lobe. They're lower in those that are considered MRI negative, or in those that have large malformations for which we're trying to remove a portion. Interestingly, in those that have, in children that have an epileptic encephalopathy, if you do seizure surgery in 3 years or less of them experiencing seizures, they're much more likely to have greater increases in their IQ post-operatively. So time is, in some cases, of the essence. So there are clearly risks to epilepsy surgery, which also depend on where the surgery is being performed, how big the resection is, what type of surgical approach we take, and how close to an eloquent tissue the resection occurs. Generally speaking, cortical resections have a complication rate of about 4%, and these include small strokes because of interruption of vessels that you may hit during resection, as well as unanticipated motor deficits, which we can work very hard and usually avoid. And certainly with any surgery, there's a risk of infection or bleeding. Larger surgeries like hemispherectomies have higher complication rates, with CNS infections 10 to 12%, hematomas occurring in 4 to 8%, and then patients requiring shunts because of the development of hydrocephalus post-op, and 6 to 16%. Now, the mortality rate is very low, less than 1%, also depends on the center. But when you compare that to the mortality in epilepsy, when you look at population-based studies, patients with epilepsy have a 2 to 3-fold increase in death rate. And in drug-resistant epilepsy, the death rate is 5 times that of the general population. And seizure-related death and sudden unexplained death in epilepsy patients, or SUDEP, comprise up to 2/3 of these deaths. So deaths that are directly related to seizures or an underlying epileptogenic state. And in a study of adults, those with medically managed drug-resistant epilepsy were 2.4 times more likely to die from all causes and 4.5 times more likely to have a seizure-related death compared to those surgically treated. Now, it also matters if you become seizure-free after your surgery. So the risk of death was related to attainment of seizure freedom. Those who weren't seizure-free, regardless of whether they underwent surgery or not, were 4.6 times more likely to die at 1 year after the study entry. And so not only do we need to get patients to surgery, they have to be good surgeries, and we have to do them well. So in summary, detecting missed opportunities for children with epilepsy can dramatically change the trajectory of their lives from an early age. And kids that have failed 2 appropriately chosen and dosed medications warrant referral to a comprehensive epilepsy center. Certainly supporting medical decisions for children and their families is really important for all of us to do, even if it means encouraging families to seek a second opinion. That second opinion may lead them to only find out that they're comforted knowing they're on the right track with medications and alternative therapies, or it may open the door to an unrealized opportunity of epilepsy surgery and potentially a cure. So I'm happy to take questions.
All right, thanks so much, Anne. That was a fantastic overview. So we have a couple questions in the chat. So let me start with, what do you think, in your personal opinion, is the biggest obstacle to getting patients to epilepsy surgery?
So it's actually under recognition of the fact that they may be a candidate. So you may have a patient who comes to you and is just on 5 medications, and they have tried the diet, and they have multifocal EEGs, and they have severe intellectual disability. That may still be a candidate. A patient that has a focal seizure once a year may still be a candidate. A patient that has a seizure once every 1 year or 2 years still may have concerns about driving, about having a family when they get older. Those may be candidates. We may be able to cure somebody, get rid of that epileptogenic focus, that tendency for seizure, and that may make a huge change in their life. So it's recognition that a patient may be a candidate, and it is worth going through a surgical eval, even if only to give that family a sense going forward that, look, surgery is off the table, or surgery is something that we need to consider.
Right. So we have another question of how young can an MRI and EEG mapping be performed?
So interestingly, we're starting a resting state functional MRI program because our functional MRI that helps us to map eloquent function requires patients to be awake. And so many of our patients have to have sedation either due to age, seizure, or intellectual disability. So resting state MRI would allow us to map those functions while the patient is sedated. And so that is a new and up and coming technology that we're getting involved in at our center. And so that would allow us to map children as young as a year, 6 months. But certainly some of these functions will remap in children under the age of 6, not vision, but everything else. And so sometimes when we can't map function, we know that there is a high likelihood that they will be remapped should a surgery be done early enough in life. And so now in terms of MRI and age, something else to be considered is myelination is not typically complete until you're about 30 to 36 months of age. And so focal cortical dysplasias may not be very visible because there's not a really good delineation between gray and white matter. And so we don't get to see that blurring we would normally see in focal cortical dysplasia. So even if a child's had a normal brain MRI 2-3 times and they're not yet 3, I will repeat it after the age of 3 in my experience. So.
All right. And then we'll take one more question, and then if you wouldn't mind, and just answer any others that show up in the chat, that would be, or in the Q&A, that'd be great. But the last question would be, how do you decide who gets a stereo EEG or conventional grid or strips?
Okay, so we try to go the least invasive route and see if a patient is eligible for a stereo EEG because the risk of complications is so much lower. But but stereo EEGs have a limitation in that there's a bolt attached to the depth. And so bolts are maybe 7 millimeters or a centimeter. And so you can only have a resolution to a certain degree. And so sometimes when we know an area of eloquence, like language or motor, is right next to the area of seizure onset, we know we have to get down to the millimeter and put a grid or strip down in that area. And so sometimes we'll do both, but that's one of the main reasons why we may go to grids and strips.
Great. Well, thanks so much. So why don't we go ahead and transition over to our last speaker, and Dr. Hislop can continue to answer questions in the Q&A, and then if there's any time left, we certainly are willing to take other questions at the end. So our next speaker is Dr. Emily Spellbrink. She is a clinical associate professor in neurology and pediatrics at Stanford University. She did her child neurology residency here at Stanford, but then did her epilepsy fellowship at UCSF. And then she also has a special interest in epilepsy genetics as well. But today she'll be talking about infantile spasms in terms of diagnostic treatment challenges and when the stakes are high.
Thanks so much, Bill. So I'm going to try to get through a lot of material a little bit quickly here, but I do want to talk about infantile spasms because I think they come up in a lot of our general clinics. And there's a lot of uncertainty still surrounding them. These are my disclosures. And I would like to mention specifically, I will talk about vigabatrin in this talk, and I have been compensated to complete a survey demonstrating my adequate knowledge about safety in the use of vigabatrin for the REMS program. Hopefully not too much conflict, but as that was mentioned here. So objectives for this talk, I'm using a single difficult case to try to identify ongoing uncertainties and challenges in infantile spasms, to review current recommendations for and address challenges associated with urgent workup, and to review and evaluate current evidence for best first and second line treatments for infantile spasms. I'll start with a case presentation. So a child presents at 4.5 months old. This is an ex-full-term boy who had spells of limp unresponsiveness with staring or up gaze, and these spells were captured on video EEG and determined to be left temporal seizures. They resolved with initiation of levetiracetam, and the patient subsequently underwent workup. His development was normal, his MRI of the brain was normal, and his epilepsy genetic panel was sent, as Dr. Galantine had mentioned, we often do send these in our young children, and showed a PRRT2 pathogenic variant formerly known as a mutation. So we know that something was wrong with the panel, and this actually fits fairly well, right? This child has an early onset, infantile onset focal epilepsy, and we know, as documented, that the PRRT2 change is the most common cause of benign familial infantile epilepsy. So this family was given this diagnosis and corresponding good overall prognosis, likely of seizures to resolve as the patient outgrows infancy and likely to have overall normal neurodevelopment. But then at 9 months old, the patient presents with a new form of clustering events of concern, sudden raising of the hands with the eyes rolling upward. And I will play these for you on video and read you. I thought mom gave an excellent description. I didn't have this video at the time, but you can see what the patient does as I read. Mom says, I think it was a seizure or a series of tiny mini seizures. He would suddenly raise his hands that were holding a bottle and his eyes rolled up. It would be a split second. There he goes. There's one of them. And he would get back to normal, but then he would repeat this weird jerky movement. It's almost like hiccups, but it's not. And so this is what he was doing. You saw about 3 of them go by just there where he'd suddenly move the arms. And unfortunately, I did have to obscure his face, but the eyes kind of roll up and he stiffens and has those little jerky movements with each episode. Per this wonderful description, you know, it was a strange, discordant thing to have a child who had a really benign sort of diagnosis that I felt was fairly well established come with this concern for really what sounded for all the world like it could be infantile spasms. But nonetheless, I said, well, he's in the right age group. We have to be worried. And we brought the child in for an EEG. And this had only happened in 2 clusters, fairly widely spaced at the time we brought him in. And so we didn't actually capture any of the spells themselves. The EEG overall appeared relatively normal. You can see some sleep spindles here, reasonable organization for age, but did have some abnormalities, some epileptiform discharges. And again, we know that this patient already has an epilepsy syndrome. So the question becomes, well, what are these spells, right? Do I write them off as a myoclonic seizure? Do we increase his levetiracetam he's already on? Kind of what are they? And I had enough suspicion from the description that mom was giving, and then later from the videos as well, that I said, you really need to come back for a second EEG in a couple of weeks, because if we don't capture things the first time and spasms tend to progress, then it's worth doing a repeat EEG, which may show you either worsening or actually allow capture of the spells. And here's baby. So just to orient you, this is baby's EEG hat. This is face obscured. Here are 2 arms sticking up, and here's baby's body in a sleep sack. And I'm going to play this EEG. And as we go across the screen, towards the middle of the page, you'll see this large, slow wave complex, and baby's arms go out just as they did in mom's lovely videos. We finally caught the event, and surely it is an electroclinical infantile spasm. It happened in a cluster in this video. Infantile spasms are overall quite rare. I would think more folks on this call probably have had to rule out infantile spasms than have actually seen positive cases. 2 to 5 per 10,000 infants overall, and they consist of basically epileptic spasms, which is a type of seizure, happening in infants. And so the 3 ways that these can sort of appear are flexor, which means head and neck flexion forward, extensor with stiffening and extension of the neck and extremities, or mixed, in which, for instance, there might be a head drop and extension of arms, or there might be some asymmetric nature to the spells that otherwise appear like these short little flexions or extensions. There's an initial contraction phase followed by a more sustained tonic phase, and there may or may not be an associated ictal cry. They last less than 5 seconds. They most often occur in clusters, with the classic story being clusters going into or coming out of sleep. And infants usually will pause in, for instance, if they're crying around the cluster, they usually pause when they experience the stiffening event itself. They may or may not have eye roll, eye up gaze associated. By definition, infantile spasms all occur of onset less than 2 years of age. In fact, most of them less than 12 months. And not uncommonly, they ride with a few other things. So you can have infantile spasms in isolation, as our patient did in the case presented, but often they may run together with an abnormal form of background activity on the EEG called hypsarrhythmia, and with some either neurodevelopmental stagnation or regression. And when these things occur in triad, the patient is said to have West syndrome. Infantile spasms can happen in these clusters that go on for quite a long time. And they're not the same kind of emergency as a seizure that would go on for 10 minutes, 15 minutes, 30 minutes, where we really have to rush someone in and load them with Ativan. But they are a neurologic emergency in that they're a marker of risk, right? Baby's not going to maybe stop breathing and turn blue in that moment, but ultimately these children are at risk of high risk of coming to harm with worsening epilepsy, as well as really significant neurodevelopmental impairment if we don't get to them quickly and treat them appropriately. And for this reason, there's been a strong push from organizations such as the Infantile Spasms Action Network to really inform families. Families are supposed to see the signs, to these clusters as described, take a video, get that to the doctor. Sometimes that's you getting it to us. And we certainly review a lot in this day and age. And then to obtain a diagnosis, which is supposed to be confirmed with your EEG testing, and then prioritize getting to exactly the right treatment. So this seems so simple, and it's a wonderful tool to inform families. But in fact, families come to us expecting this certainty and sudden diagnosis. And there are actually a lot of challenges and a lot of uncertainty surrounding infantile spasms in their care. So we actually don't know what they are biologically, when, how, and why they portend such a poor prognosis, how we can best stop them, although I hope to present some of that today, and how we can improve the long-term prognosis for our children who have them. Covering all of this would be an hours long talk, but I'm going to try to focus today on the challenges surrounding diagnostic uncertainty and treatment selection. Beginning right into diagnostic uncertainty, the first challenge I'd like to highlight is that spasms have many mimics. And this may be something that's already familiar to a lot of you. We have children in this age range who are moving their, progressing with their brain myelination, and they have a lot of kind of jerky and unusual movements. They're also learning to use their new motor systems in whole new ways. And so anything from a Bell's phenomenon, when children's eyes may roll up as they're falling asleep, to shuddering spells, and children who are excited and learning about their environments may be misinterpreted as infantile spasms. We also have other seizure types that are easily confused with spasms, and certainly other organ system problems such as Sandifer syndrome with GI reflux and stiffening that may be looking like a spasm. And often these things can only be discerned with a video EEG. Of note, using our case example, this is really important, right? Because again, if I just increase my patient who has known epilepsies, levetiracetam, that might treat something like a myoclonic seizure, a tonic seizure, but it may not, in fact, certainly will not be a first-line treatment for children who have infantile spasms as opposed to one of those diagnoses. So this makes it important to review how we diagnose infantile spasms. First, we have to have a clinical index of suspicion. So any child in the appropriate age range, particularly a year or less, but even up to 2, who's having stereotype clusters of flexor, extensor, head drop, eye roll, spells, particularly in clusters, we need to be concerned that those might be infantile spasms, and we should be doing a lot of negative EEGs to make sure we don't risk this high stakes diagnosis being missed. Especially if there's any associated developmental concerns, arrest or regression, we really need to have a high index. And if we do have a high index of suspicion, we need to strongly consider doing serial EEGs if we get an initially reassuring looking EEG, particularly one that doesn't catch spells. On the EEG, we're looking for either capture of the spells themselves, which could be hopefully electroclinical epileptic spasms, and or the mimics. And if we see clear mimics, that's great news. And if we fail to catch the spells, we may still see between spells, the background show this activity called hypsarrhythmia, hyps meaning high, arrhythmia meaning irregular rhythm. More to come on that shortly, but again, absence of this does not exclude spasms as we saw in our case. Diagnostic challenge 2, once we've gotten our patients onto EEG, the infantile spasms themselves and the hypsarrhythmia aren't always clear, and they aren't always immediately captured. And this can be frustrating to our families, and the uncertainty certainly is a challenge. So electrographically, infantile spasms appear in 2 general flavors. The first one is that there can be an electrodecrement that happens, and that I'm showing over to the left panel, and or there can be a large slow wave complex that happens with the spasm part. There are many other subtleties and varieties within an individual patient. Clusters tend to look stereotyped electrographically, but between patients, you can tell there's quite a broad spectrum. There may be asymmetry. In the right panel, you can see this child has had a large left MCA stroke and it has attenuation generally over the left brain. And so you see the complex is much better formed over the right brain. And then in general, we tend to see overriding fast activity to either the electrodecrement or the slow wave. And usually this coincides to the motor portion of the spasm that we hopefully could see on video. In addition, if we don't catch or around catching spasms, we may see this pattern called hypsarrhythmia. Classically, again, to our general audience, this looks like TV static. It looks the same right side up and upside down a lot of the time. It looks like really high voltage waveforms greater than 200 to 300 microvolts, disorganized chaotic activity, multifocal embedded spikes. And we really must capture slow wave sleep to know that this pattern is not present on the EEG, because sometimes it can hide there even after spasms are not present. But this is the lucky case, right? If we get this fully developed and we happen to catch it, then we might be in all agreement that this is clearly hypsarrhythmia and spasms. But and please forgive, this is my not as adequate version of this figure, but Dr. Hussein and colleagues published a very nice image that shows the spectrum of hypsarrhythmia going from the far left panel being an abnormal EEG, right? We've got some spikes, polyspikes in the back, but really clearly not hypsarrhythmia. It still has some organization. It's not so chaotic that it looks like static or looks the same upside down and right side up, all the way over to the right-hand side where it does really look like that normal pattern. And in between, it's like, well, most of these seconds have some high voltage multifocal spike activity, but not all of them. And here, well, it's kind of chaotic, but sometimes the spikes are starting to synchronize and organize together. And in fact, so when we tried to get epileptologists to agree about this, there was a Delphi consensus to try to define hypsarrhythmia back in 2004 and could not reach consensus among experts. And then more recently, with the publication of this paper by Dr. Hussein and colleagues, 6 different EEGers had only a 0.4 kappa agreement, meaning moderate agreement between experts at best at what was hypsarrhythmia. And when we move into modified hypsarrhythmia, which can be due to factors like interhemispheric synchronization, maybe 2 or 1 epileptic foci rather than true multifocality, episodic voltage attenuation, like when those things come into play and we start talking about modified hypsarrhythmia, the agreement drops even lower. So I would also mention that progression toward Lennox-Gastaut syndrome. So once you've had infantile spasms for a while and the epilepsy is starting to get worse into another syndrome, that can confuse things too. Do we call this Lennox-Gastaut or do we still call it hypsarrhythmia? So when in doubt, I would recommend to use something called a based score. This is a score published in this publication by Dr. Meidinger and colleagues. And it basically requests that we take the most severely abnormal 5 minutes of our study. Again, we can't call the study a 0 or a 1 with just 5 minutes. We have to look at the whole study. So that's just normal or mildly abnormal, right? But not epileptiform. But anything more than that, we take the worst 5 minutes and we look to see how many spike foci are there, how big is the background, is it large amplitude background without multifocal spikes? Are the multifocal spikes present all the time or just in 50% or less of the bins? And so it takes these factors and allows us to get over time within a patient, a kind of an idea whether things are getting better or worse, and to compare EEGs even when we have some disagreement between our readers. Diagnostic challenge 3 with infantile spasms, I think, is also well illustrated with our case. So spasms can occur with or without a typical cause and with or without typical development. Our child was without a typical cause and had absolutely normal development. And the key thing about this case is that this is actually the child in which you're going to make the most difference, according to the studies that we have. Children who have normal development prior to spasms onset and who receive very prompt treatment for their spasms do the best, particularly in terms of developmental outcomes. So this is kind of our classic workup flow. The 2 probably highest yield pieces are the MRI of the brain, along with, of course, a good H&P EEG and opto exam. And then second piece being genetic testing. But even after that, 36% of our kids are having no clear cause. And so we really have to, even in kids who seem quite normal, we have to have an index of suspicion for this, this problem, as it's very high stakes to diagnose. So back to our patient, we showed that he had electroclinical infantile spasms. And given a case report of another patient with a PRRT2 genetic change who had successful treatment with vigabatrin. And I will mention also, given that the family was about to undertake a large move logistically, they decided to start on vigabatrin. We put him to 160 milligram per kilo per day, and an EEG reassessment was planned after 2 weeks of this management. This brings us to our treatment challenges. Did we do the right thing? And should we have done this in this child who has like a benign diagnosis and normal development? So what would happen with no treatment if we missed this and this were spasms and we didn't treat it? Mortality is very high, 65 times that of other pediatric epilepsies generally. Development, 90% of these people without treatment will develop intellectual disability, and only 9% with normal or mild impairment at 12 months. Seizures, 45% of these children will be going on to develop other seizures and epilepsies, 20% with refractory complex epilepsies such as Lennox-Gastaut, and only 17% long-term with normal EEG. So we have to find something to help. What treatment would help the best? And I think as we weigh this, the 3 areas we want to address are clinical evidence. For instance, does the patient have tuberous sclerosis? That leads us down a specific treatment path. Is this a first or a relapse presentation? Second is scientific evidence, and I'll try to cover briefly our 3 large clinical trials, although there are also meta-analyses I'll point you towards that we won't have time to go over. And then logistics, and that certainly came into play for this patient. What can be started quickly, affordably, consistently, and safely? For our evidence basis for spasms treatments, there really are at this point 2 clear first-line treatments. And harking back to Dr. Gallantine's talk, I will mention that a pyridoxine trial, while not really considered a first-line treatment in so many words for spasms, many consider that also to be a relatively first-line thing to try, right? Because if you're missing B12, everything else is, if you're missing B6, everything else is going to fade into the background in terms of not being as effective. So the first-line treatments accepted are hormonal, which could be either injected ACTH or oral corticosteroid. And these have been known since as early as 1958. And then vigabatrin, which has been known as early as 1977 and is in fact the first-line treatment above hormonal treatments for children with tuberous sclerosis and infantile spasms. And then the second line for refractory spasms can include things like keto diet. And there's been progressive study of this, and particularly out of institutions such as Johns Hopkins. And there are then other anti-seizure medications. And these should not standardly be first-line treatments for spasms. There's good evidence, I don't have time to review here, that treatment goals need to be full electroclinical resolution of the spasms, meaning not only have the spasms stopped to be seen, but also the EEG is free of hypsarrhythmia or electrographic subtle spasms. And what data do we have that's driving all this? So we have several large prospective studies, which I will review in the next slide. And then we also have, I'd like to point you to these 2 excellent meta-analysis and review of many, many other studies that have been done that are a smaller scale. But I think these are the big studies that have kind of shook things up and really defined our field more recently. So the first is the UKISS study. This is back from the early 2000s. And this was the first study that established these real first-line meds more clearly. This was out of the United Kingdom, 107 randomized children, infants, I should say. These children received either hormonal therapy, which was either prednisolone orally, ACTH injected, or vigabatrin. And the outcomes were assessed in terms of clinical spasms. So looking at whether they had, we're still having spasms that someone could see. There was not an EEG measure, unfortunately, on this study. But again, it was a landmark first study and they just got it done. And these children were followed all the way out to 4 years of age. And you can see that treating with steroid or ACTH with hormonal treatment produced quite an impressive resolution in spasms at 14 days. And vigabatrin, slightly less. Again, children with tuberous sclerosis were excluded here. So this study suggesting strongly that hormonal might have a better effect in stopping spasms. Not adequately powered to discern between the 2 hormonal treatments, as have none of these studies been, unfortunately. And then looking, interestingly, despite the fact that in general, earlier stopping spasms has correlated to better outcomes, in this study we found at 14 months and 4 years, the only group that did better in terms of their developmental outcomes were the cryptogenic children, so children without a known cause for their spasms, who then also took hormonal treatment. and that really improved their developmental outcomes significantly. There was no difference overall by what type of treatment and how many seizures that the children had who were all treated with first-line meds. The second study is the NISC study. This study is out of a number of organizations in the United States, coordinated with first author out of Colorado Children's and through a number of specialty centers in the US that coordinated through this organization called the Pediatric Epilepsy Research Consortium, or PERC. 282 children, unfortunately, were not randomized, but were really treated according to standard protocols. It's just that there was some influence by parent choice and provider in what the children got. And I'm going to, well, let's see. I'm going to run through some of the highlights of how this differed from the other studies. So the non-randomized, the fact that children were slightly older up through 2 years with spasms, higher doses overall for their ACTH and their vigabatrin. And you can see, and the other major point is that they measured electroclinically for freedom from both spasms, both clinical spasms and any EEG signs of spasms or hypsarrhythmia. And so as you can see, the numbers are quite a bit lower in this group than they were in the group that measured only the clinical measure of spasms, and that might be as to be expected. But interestingly, again, the children with the hormonal treatment fared quite a bit better than those with vigabatrin. And here again, suggestion of ACTH being better, but not powered to show compared to oral prednisolone. And these did not measure any long-term developmental outcome study, but interestingly, it's one of the only studies to find a lack of effective etiology or pre-existing spasms on, pre-existing developmental challenges on ultimate development. And so the ICISS study is the most recent. And this is one you may have heard of because it's suggested more recently this question of whether combination therapy, so using both vigabatrin and a hormonal treatment, might be superior to using vigabatrin by itself. And this study did not exclude tuberous sclerosis because everybody got vigabatrin. So they thought that those kids would be okay to include. This was among a number of centers throughout Europe and Australia and quite a large number of randomized children. And it did show, generally speaking, that combination therapy seemed to stop a lot more kids. And I'm gonna flip to this table because I think I recreated this as perhaps the best direct comparison. So again, this UKIS study is only clinical measures. The ISIS study is only clinical measures for these big numbers, but over here with next to the EC, they did electroclinical on some of the children between 14 and 21 days. They did an electrographic measure as well. So they had some electroclinical measure as well. And then NISC, of course, was all electroclinical and measuring freedom from spasms. And if we look and compare the numbers, so of course, if you look at the straight number here, right, combination therapy at 89% resolved clinically only looks really strikingly much better than any of these treatments by itself. But if you really dig down a little bit, there's an ongoing study of this, because if you look, right, so 2 weeks for the NISC study with electroclinical freedom, 68% were free with hormone alone, right, with ACTH alone. And then we looked at the combination therapy with hormone and vigabatrin, and we look at the electroclinical at 14 to 21 days, and it's 66%, right, with the combo therapy. So it's not really all that different. So I think what a lot of folks are doing these days is taking that information and using it as fuel to, if you're needing a second treatment because either spasms are coming back, you want to make sure that you that you use a good combination of hormone and vigabatrin together. And interestingly, with the combo therapy at 18 months, treatment did not predict developmental outcome being any better using the Vineland behavior scores. So I put the other predictors on here. So I'm sorry, we're running just a tad behind here. And so I'm going to kind of skim over these. I think that most everyone knows the side effects that are associated with ACTH. And I skipped this slide briefly. There are many other smaller studies that also support hormonal therapy very strongly. That brings us in our case to why didn't I just use ACTH first line? There's a lot of associated morbidity, mortality. I was concerned with travel about both infectious exposure as well as having side effects and not immediate access to a hospital, or what if the medication ran out and he wouldn't have access to get more? And it costs $71,000 a vial, with taking at least 1 to 2 vials to complete a treatment. Alternatives aren't great either. We know that vigabatrin can result in permanent irreversible visual field loss. Again, overall low, less than 5% of children for less than 6 months of treatment, but that's a pretty scary long-term thing to think about. And prednisolone, again, also similar side effects to ACTH and similar concerns about abrupt withdrawal. I put in also a summary of those from the side effects from our free large studies. So in our infant, I question in hindsight, should I have just started with a hormonal treatment? But in any case, we started with vigabatrin. And unfortunately, the spasms did persist despite vigabatrin. This was based on this case report of someone with the same change. So what next? And we have good studies, not only from our combo trial, but also from Dr. Nupp and colleagues who did the NIST trial, did another study showing that conversion from a first-line treatment with hormone to a second line with vigabatrin, or from a first-line vigabatrin to a second-line hormone, or from anything else to hormone, actually has a really good probability of success. So more than half of patients are responding to that. Well, you'll notice not treating with first-line therapy leads us to almost zero success. So our patient was changed over to ACTH, added on to the vigabatrin actually at the time, although vigabatrin was eventually weaned at 6 months without event. The ACTH did resolve the spasms, and he's had no further seizures or spasms and is on track with his development so far in his new location. So this brings us to whether long-term treatment really helps in the longer term. And this figure is care of that group that I mentioned, the PERC group that helped coordinate sites for the NIST trial. They're now doing a larger biomarker study to try to understand spasms and their causes, and whether when long-term treatment can help better. But we're still not there yet, right? We have new onset spasms patients, only 55% of whom respond initially. And of those, a third are going to stay remitted, a third are going to relapse, and a third are going to end up with other kinds of seizures. So we have to know better how to sort these kids, whether they're ways that we can better target our treatment. And then of course, also in terms of the development, with even the combo therapy not showing clear differences, jury's somewhat out, they're still waiting on 5-year data. How are we going to get to that, the goals we really want for our patients? So I'm going to briefly put up my, my summary slide of kind of what we've covered in here. High index of suspicion for spasms, knowing that this is the most prevalent epilepsy syndrome in infancy, that anyone who has recurrent events that sound like spasms really needs an EEG, and we should consider even serial EEGs if we have a high worry. These are a marker of a neurodevelopmental emergency. If we stop the spasms fast with first-line treatment, we may really improve outcomes for our patients. I'm going to say thank you with a picture of one of our grateful spasms patients who agreed to be on our website and take any questions.
All right, thanks so much, Emily. That was fantastic. Well, I would like to thank both of our speakers today for giving 2 great talks, and also thank the attendings for attending our webinar. We are willing to stay on and answer a few questions if anybody has those, but if not, certainly we wish you a great afternoon. At this point right now, there are no questions in the box, but if there's other questions, we will hang around for a few moments and see if anything pops up. But otherwise, you guys can have a great afternoon. I have just been prompted to also remind you that you will be getting an email with instructions on how to complete your evaluation and claim your CME credit a little later on today. Or actually on Monday, sorry. Yep. Okay. All right, well, I do not see any, let's see, we've got some questions coming in here now. So there's a compliment. The presentations were excellent and fantastic. Thank you so much. For the following ages, as another dilemma between behavioral problems such as ADHD, which is resistant, and hypsarrhythmic epilepsy infantile spasms, could both diseases might be a potential cause of treatment response for one or the other?
I'm not sure if I totally, can you hear me, Bill? Okay.
Yes, I can hear you.
I'm not sure if I totally understand the question. So ways I could imagine this. So one is, how do I know if the child has ADHD versus hypsarrhythmia and infantile spasms? Typically, we don't diagnose ADHD in an infant age group. So I would think if you're having a child who's really having sort of arrest or regression in a very young or infant age group, you'd almost certainly want to get that child assessed with EEG or depending on the characterization of what the problem is, whether it's delay or regression. But with regression, we often would, for an infant, want to work up with an EEG test. We shouldn't be diagnosing ADHD kind of in the less than 2 population without, really having excluded many other things. The other way I could imagine that is how would you know if ADHD could be a sequela of infantile spasms? It potentially could, but usually the deficits we see are even much in excess of classic ADHD after we've seen children with infantile spasms.
And then we have another question that says, based on ACTH and prednisone effectiveness, do you think there's a possibility that other immunomodulatory therapies could potentially be helpful for infantile spasms? That's an interesting one.
Yeah, no, that's a great question. I think there's a lot of study ongoing in that area. I think there's a question about even whether things like the keto diet might be related to that. And then aside from that, I think even some of our newer neural steroids have been thought to be tried, but there isn't good existing trial data. We're just actually getting to the larger trial data with our established treatments, but it's a great avenue for next study.
So there was a question for Dr. Hislop about patients with TS and then patients with lissencephaly. Are they potential candidates for surgery?
So absolutely, TS for sure. And we have a large TS program and lots of surgeries for those patients. The trick is identifying the right tuber that could be epileptogenic or the surrounding tissue to that tuber. And even patients with lissencephaly, even patients with these broad malformations can be considered. More recently, we've been able to show that patients that have some pretty extensive malformations may only require small resections in order to render them seizure-free. So it's worth a pre-surgical eval.
Right. This was for Dr. Spellbrink. So in patients who've had a relapse of their spasms while on ACTH, what other line of therapy would we consider trying? Oh, you're muted, Emily. Oh, you're muted, Emily. Sorry.
Sorry, can you hear me?
Yeah, we can hear you now.
I'm going to go backwards a little bit on my slides because I had this on here as well. So I think that the best evidence we have would be then for switching. So if you're on ACTH and they're failing, then vigabatrin as the next the next line treatment is the best current evidence. But there are some other extenuating things. So one thing that has been done is if the patient's on low dose ACTH, some folks will switch to high dose. Those have only been looked at in small studies, but the ones with asterisk at the bottom are the ones that support that may be helpful. So I think the clearest answer with the data we have is to go to vigabatrin, but I think there's some other smaller studies that have other data you could take a peek at.
Great. All right. Well, once again, I appreciate all the time for the speakers today. It looks like we've answered all of our questions. And so I would wish you guys a great afternoon and hope you have a wonderful weekend. Thanks so much for joining us.